Next, on to neuroradiology. This is a person who has a normal MRI, although to me it kind of looks like, oh, you know, Thor and Odin. This is the eyes, the nose, the little beard, the mustache there. This is actually the fourth ventricle. And this is a normal brain MRI with great detail. Normal structures. These are all the normal structures. And now let's say that you don't know what a normal structure is. Look on the bright side. Does it look the same on the other side? You got two at the same time and they look equal? It's normal. We are made in mirror images on both sides of our body. So if the other side looks the same as this side, it's normal. Normal MRI. Look, absorb, meditate. Om Namah Shivaya. Next. This is a normal MRI of the brain. This is your cerebellum. This is the fourth ventricle. This is the corpus callosum. This is the normal brain. That's my nose. That's my pharynx. Pharynx, sinuses. This is the pons and your medulla oblongata and your brain stem. Cerebellum, normal brain, corpus callosum, ventricles, pons, brainstem. This shows you that the MRI is superior for looking for the posterior fossa. The MRI is superior looking at the brainstem. The MRI is superior for looking for cancers, for abscesses, infections. The MRI is superior for looking for everything except blood. When you're looking for blood, the best thing is a CAT scan without contrast. Well, look at this. It's a CAT scan without contrast. Gee, I don't know a corpus callosum from a corpus cavernosum. I can't tell, but I'll tell you what, I don't have that thing on the other side. So this must be abnormal, because I only got one of them. So this is an epidural hematoma. Why epidural? Because it's pushing in the brain. Epidurals are arterial. Epidurals have higher pressure. Epidurals can push in the brain. Epidurals, higher pressure pushing in the brain. Epidural, like a lens. Epidural. Epidurals are higher pressure. This is the brain. Sorry, I got a sort of an egg-shaped brain here. This is an epidural because it's higher pressure. It's an arterial bleed. Subdurals are venous bleeds. Because they're venous bleeds, they're lower pressure. Because they're lower pressure, the venous bleed conforms and goes around the shape of the brain. Now, you can herniate with either one of them. It's just that one makes a different shape than the other. The most accurate test for blood is a CT scan without contrast. This is a big collection of blood compressing that lateral ventricle. You notice that this lateral ventricle with cerebrospinal fluid going black is bigger than this one, smaller. Why? Because the bleed has compressed it. Another epidural, lens-shaped, clearly visible because blood looks like contrast on a CAT scan. Blood has the same density as contrast on a CAT scan. Subdural, going around the brain, conforming to the shape of the brain. Now, you'll see here that the ventricle has been compressed, obscured, obliterated, eliminated, gone. Here, this ventricle is open. This is the sign of pressure and mass effect. This is a person who's trying to herniate their brain. This person needs intubation, hyperventilation, mannitol, and surgical evacuation. Intubation, mannitol, and evacuation to drain this out before they herniate. Subdurals conform to the shape of the brain. How do I know it's an acute subdural? Because acute blood looks white. Acute blood looks white. Acute blood looks white. Acute blood looks like contrast. Acute blood looks like contrast. Acute blood looks white. Chronic blood looks darker. Chronic blood looks more like cerebrospinal fluid. You notice it's not shifting the brain. The ventricle is open. Whereas this one is shifting the brain. The ventricle has been squished shut. Chronic. The blood has started to be reabsorbed. It's lower density. Looks more grayish. Chronic, lower density, not making you herniate. This is a person who's got a chronic subdural hematoma. You could have these for years. It doesn't necessarily mean anything. If they're asymptomatic, you do nothing. If they're symptomatic, you drain. This one is symptomatic. You see that? Get back over there. Get back over there. Get back over there. Move over. Move. What are you doing back over there? You're supposed to be over there. Because this is a huge, massive subdural hematoma that has caused brain herniation. In other words, it's not whether it's a subdural or epidural that tells you whether or not you're going to herniate. It is whether it is larger or not. The larger one is worse. So, this subdural hematoma pushes the brain over, and the larger one is worse. Intubation, hyperventilation, and evacuation as soon as you can drill a hole through my head. This is a person who's taken this structure, should be over here, and has herniated it over. If they're not drained now, they will be dead or permanently brain damaged. Subdurals or epidurals. Subdurals conform to the shape of the brain. That doesn't mean it's always benign. It just means that it goes around the brain. You could have benign, slow, chronic subdurals that don't have many symptoms, or you could have overwhelming large ones that cause herniation. You just don't get chronic epidurals. Epidurals are always acute. Epidurals are always acute. You can have a chronic subdural, but you can't have a chronic epidural. Next one. Here's a ring-enhancing lesion. A contrast or ring-enhancing lesion in the brain. This is a contrast or ring-enhancing lesion around the brain on an MRI. Now, ring-enhancing lesions, also known as contrast-enhancing lesions, ring or contrast-enhancing lesions. Ring or contrast-enhancing lesions are basically two things: cancers and infections, abscesses. Cancers and infections or abscesses. So ring or contrast-enhancing lesions can be two types of things. Now, if this is a person who is HIV positive, you should just treat for 2 weeks with pyrimethamine and sulfadiazine and see if it gets better. If this is a person who's HIV and gets better with pyrimethamine and sulfadiazine, then you know that it's toxoplasmosis. Because in HIV, 90% of the time, it's going to be either toxoplasmosis or lymphoma. In HIV-negative people, you've got to biopsy because you can't determine if this is a cancer, an infection, just from the radiologic imagery. Because the radiologic test is never the most accurate test, and you can't tell if it's a glioblastoma or Staph aureus. HIV-negative biopsy. HIV positive, 90% of the time, it's going to either be toxo or lymphoma. So therefore, we can treat empirically and see if it gets better. This is what a ring-enhancing lesion looks like on an MRI. The same lesion on a CT scan would still be ring or contrast enhancing. The blood-brain barrier has broken down around the lesion and causes the extravasation of small amounts of contrast into the parenchymal tissues. That's why the contrast is enhancing or lighting up the lesion. That's what contrast is for. It's not to look for blood. I don't need contrast to look for blood because blood looks like contrast. What is this dark stuff around the lesion? It is edema. It is edema. And it is the edema surrounding a ring or contrast-enhancing lesion. So this is cerebral edema surrounding this lesion. These are both ring-enhancing lesions. MRI, CT. MRI, CT. And the edema around it. What should this person be treated with first? The answer is steroids. Steroids for the brain are used to decrease the edema around the lesion, for the swelling around the lesion, to decrease the likelihood of herniation and seizures. Steroids will not help in subdural and epidural, but steroids will help with cancers and the edema surrounding cancers and infections. This edema should be treated with steroids. This is a person who's got an MRI showing multiple metastatic lesions. That's a metastasis, that's a met, that's a met. The dark stuff is the edema in the brain surrounding the metastases to the brain. This person needs steroids. Steroids in the brain are to decrease the swelling surrounding cancers and infection, decrease the risk of herniation, decrease the risk of seizures. Cancer, edema, give them steroids. Now, the lesions that are metastatic to the brain, lung, breast, colon. This is understandable because lung cancer is the #1 cause of cancer in the United States, of cancer death. Therefore, lung cancer, it's expected that it should cause metastatic disease to the brain. It's simply the #1. Breast and colon go to the brain simply numerically. If you say that 3% or 5% of lung, breast, colon, prostate go to the brain, it's understandable. They're the most common cancers. 5%, it goes in the numbers. Why is melanoma #4? Melanoma likes to eat your brain. Although melanoma is only 1 to 2% of all cancers, all cancer deaths, that is, it has a very unusual predilection for metastasis to the brain. So melanoma and prostate cancer are up here very close to each other as a cause of metastatic disease to the brain. Even though prostate cancer is enormously common, it stays local or goes to the bones. Melanoma likes to eat your brain. This patient, multiple lesions here with contrast enhancement and also edema surrounding these lesions. Next image. This is diffuse symmetrical atrophy. This is a person who's got enlarging ventricles and hydrocephalus, but also you'll see that the gyri and the sulci are abnormal. This is diffuse symmetrical atrophy. This is a person who could have HIV. This is a person who could be an alcoholic. This is a person who could be an alcoholic, have HIV, or be 100 years old. This is diffuse symmetrical atrophy, and this is the enlargement of the ventricles, and this is a person who has dilation of the sulci. And this is diffuse symmetrical atrophy. Age, alcohol, HIV effect on the brain. In this case, it happens to be HIV, but you couldn't tell that just by looking at the CAT scan. Diffuse symmetrical atrophy, where the gyri and the sulci become enlarged. The sulci are becoming enlarged, which is the space in between the gyri. And the ventricles become enlarged as the brain floats out to fill the skull, because the body doesn't want the brain flopping around, hitting the skull, hitting the skull, hitting the skull, so it floats out to fill the calvarium, the inner portion of the skull. Diffuse symmetrical atrophy. This is a head. Yes, it's a head. Well, why am I showing you skull x-rays? What is the utility of the skull x-rays? Okay. The utility of the skull x-rays is that what happens is that the person gets multiple punched out lesions. Skull x-rays are not useful for fractures, because if you have a fracture, what you really want to know is there blood? So if you're looking at head trauma, don't order skull x-rays. If you have head trauma, the best thing to look at with head trauma is a CAT scan. With head trauma, the answer is loss of consciousness equals CT, not skull x-rays. Just say no to skull x-rays, because you could have an abnormal and have no blood. You can have a negative skull x-ray and have blood. So if I'm really looking for blood, I need a CAT scan. Trauma to the head, I'm looking for blood. So therefore, I'm looking with a CAT scan. This is myeloma. Myeloma, multiple punched out lesions, sometimes known as a salt and pepper skull. Multiple punched out lesions, sometimes known as a salt and pepper skull. Multiple punched out lesions. You see this the skull looking a little like Swiss cheese. Myeloma is one of the only remaining indications for skull x-rays. Now I know some of you might say, hey, but where I'm from, we always got skull x-rays with head trauma. We never got a CAT scan. We never got a CAT scan. Never. Well, why not? Because we didn't have a CAT scan. So if you didn't have a CAT scan and you had head trauma, you might get skull x-rays. Just remember, skull x-rays can't tell me what I really want to know, which is, am I going to the operating room to have my blood drained? Myeloma, multiple punched out lesions and lytic lesions. This is a person who has an MRI of the spine, and this shows a lesion pressing against the spinal cord. This thin white thing going down here is the spinal cord. This is a person who's got compression of the spinal cord. You can't tell what from. This happens to be metastatic lymphoma pressing against the cord. This is to show you how beautiful and wonderful the MRI is for looking at the spinal cord. Here is the vertebral bodies. Here is the disc. Here is the spine, and the thin black line is cerebrospinal fluid. The thin black line on either side is cerebrospinal fluid. These are the spinous processes of the vertebra, as well as the cartilage in between them. This is the skin and soft tissue and fat. Look how beautiful each layer is shown. You could see that the cord is very different from the cerebrospinal fluid bath that it sits in, is different from the bone, from the nucleus pulposus of the discs, is different each piece. It's very detailed. MRIs revolutionized neuroradiology. CT myelography, putting a needle in this and putting in contrast, is a dead test. Anybody who used to get a CAT scan with a myelogram, putting contrast into the cerebrospinal fluid and hanging them upside down with their ankles to see if the contrast gets blocked, is a dead test. Don't do it anymore. The CT myelogram, is only useful if you don't have an MRI. This is a dead test and has been replaced by the MRI. Magnetic resonance imaging. More details, no needles in my spine, no being hung upside down. This is a facial film looking at the sinuses. This is to show you opacification of the sinuses. Open, air. Here we have opacification of the sinuses. Here we have air, here we have opacification. So this is sinusitis. So this is sinusitis, and this is air in the sinuses. So this is opacification of the normal sinuses. These are the frontal sinuses, open, air-filled. That proves that we were meant to sing, because no one has yet shown me anything that shows there's any benefit to having a sinus except having a better tonal quality of voice, like a loudspeaker for your mouth and face. Because other than that, the only point of sinuses seems to make your skull lighter and create a space for infection. Sinusitis. Now, what's the most accurate test for sinusitis? Is it a CAT scan showing opacification here of the sinuses? No, it's a biopsy. Can you look at that CAT scan and tell me if there's strep, if there's anaerobes? Can you look at that CAT scan and tell me if there is an infection in there? And the answer is the radiologic test is never the most accurate test because you've got to biopsy and put a needle into those sinuses. Air fluid level, opacification of the sinuses.